Erin, I think we're set to launch. Hi, everybody. Good afternoon. On behalf of the Colorado Navigator Community Health Worker Promotor de Salud Alliance, as well as the Patient Navigator Training Collaborative, I'd like to welcome you to the second session of our Mental and Behavioral Health series with some of the funding that we have through the Colorado Health Foundation around barrier reduction and access to care. So we're very excited as we continue to launch this series all throughout May into early June. Every Wednesday afternoon, and we're very excited as we had Camille Harding join us last week to talk a little bit about the overall landscape of mental and behavioral health in Colorado with some of the great survey results and information around resources and care. And we're going to continue on that theme, talking a little bit about the legislation and what are the current opportunities for policy and that level of perspective moving forward into our session today. We have two awesome presenters in terms of Mindy, in terms of the Director of Strategic Initiatives for the Colorado Behavioral Health Council, as well as Sarah Davidson, who is the principal of her own firm, who both worked and have great experience in this area. So we're going to hear from both of them their perspective in terms of policies, priorities, and then solution-based resolution to thinking about barriers to care. So we're super excited to have these two ladies. We will punt to Sarah for our first presenter and then have Mindy joining us and share a little more about their background. In terms of the rest of the series, in May, middle of May to the end of May, we'll be also talking about assessing mental and behavioral health and particularly around suicide prevention, strategies, solutions, and resources. And then also on the 27th and then over into early June, talking about the integration of the mental and behavioral health aspects into community health work and navigation with several great folks who have worked in disease-based navigation in community health and bridging behavioral health interventions, as well as those who are in rural and frontier communities and urban areas that are specifically integrating navigators who are focused on mental and behavioral health. So it's a great series. We're really excited. When we first started planning this session, several months ago, we had no idea how timely it would be as we have the COVID pandemic and really dealing with that crisis at this time. But great to have some folks who can really talk about solution-oriented approaches and really what's on the landscape. And I think on some level, as all of us as sort of natural problem solvers, what are we going to do to help in this approach with barrier reduction around mental and behavioral health? With that, Sarah, I'm going to pass it to you, and we'll have you go ahead and start sharing your screen. And we'll go ahead and kick off today.
Great. I'm going to put my screen up here and just double check technology. Screen sharing is paused. No, I don't want it to be paused. All right. So thanks everybody for being a part of this. I was excited to do this with Mindy, and I think there's obviously a lot going on these days that hopefully we can at least go through an hour's worth of it and make a little dent in sort of the understanding of the lay of the land, both pre-COVID and current situation and post-COVID, around the landscape and legislation in behavioral health. So just to start off and address the elephant in the room, obviously things have changed a lot, seemingly overnight in some ways. So the COVID pandemic means that Colorado has really shifted in a lot of ways its way of working and decision making and policy making. So I want to go through a few things today before I turn it over to Mindy. Wanted to take a look at some of the data and rankings for behavioral health in Colorado. And I'll go through this in a little bit more detail, but I wanted to give the sort of overarching comment that keep in mind this is sort of pre-pandemic data. So I'll talk a little bit about some of the things that we'll likely see changing as we go into probably the next year or so. Want to take a look at policies that we have in place that can support behavioral health, both that have passed in the legislature last year and this year, that can really support behavioral health regardless of current circumstances. That we have some solid infrastructure in place around behavioral health, and I know Mindy's going to go into more of that. And then look at the legislative and budget forecast. We're at a very critical time right now in terms of the state legislature and the Joint Budget Committee. So I'll go through some of that and how it potentially could impact some behavioral health in Colorado. So I want to start with kind of an overarching view of Colorado and where we rank and sort of some of the things that are considered as we're looking at these rankings. So Colorado, as you can see from this slide, Colorado is trending towards one of the lower ranked states in terms of overall behavioral health. So this includes adults, it includes youth, it includes substance use, and it includes mental health. So overall, we're trending down in the bottom, sort of in the bottom half of the states. So the measures that make up, there are actually a number of measures that make up this overall ranking. A few of them, just to give you an idea of what's included, are the prevalence of mental illnesses, prevalence of substance use issues, prevalence of youth issues, including substance use disorders and severe mental illness. Looking also at people who are uninsured, people who are reporting unmet needs, people who have who are not able to seek medical care because of costs. And one other important factor in the rankings is children who have insurance that don't cover mental or emotional issues, which is a pretty critical one because, as we'll talk about in a little bit, parity indicates that mental health needs to be covered in the same way that physical health coverage occurs. So that's kind of our overall ranking. We're 29th in the nation. And that's out of 51. Washington, D.C. is considered in the state rankings. So I wanted to also break it down for you in terms of adult and youth. So the measures that make up the adult ranking are very similar to the ones I just went through, except it's only for those people who are ages 18 and over. And the youth ranking is for under 18. So the youth ranking, as you can see, we're 34th. Adult ranking, we're 33rd in the nation. Those are actually a little bit better. So the youth ranking, we had been a little bit below that ranking in previous years. So we're getting a little bit better. And I think some of the reasons for that is that there's better access to mental health care, insurance coverage is getting slightly better. And that people are being better, youth are being better identified through various sources, including schools and earlier on. So again, just a little bit more information about what we're looking at here in Colorado, which I hope can be helpful as that if you're thinking about the big picture of kind of not only prevalence, but also access to care and kind of how Colorado is doing in terms of connecting people to the care that they need. So Colorado has about a little over 830,000 adults who have mental illness, which is about just about 20% of the adult population. And we rank 36th in the nation for prevalence. So this is just a prevalence statistic, and I'm going to duck for 1 second because an earbud just fell out. So this is just a prevalence statistic, which I want to caution everybody to think about this not as a kind of a be-all, end-all data point. Prevalence, I think, gives us some information, but it's not necessarily a negative or a positive. I think when we look at prevalence, if prevalence becomes higher over the course of time, that doesn't necessarily mean that people are getting worse or Coloradans are getting worse. It could mean that we're getting better at identification and diagnosis and providing supports and services. So keep in mind that this is during quote ordinary times. So these rankings, so the information that you're seeing here is coming from our Colorado Health Institute, from our Colorado Health Access Survey from the current year that we have available data. This is during typical times. So I want to go through this, but then also talk a little bit about the times that we're in now. It's going to be, and we've seen that it's been a little bit more difficult to access care, and there have been more people who have needed different types of care and through different modes. So during ordinary or typical times, we've got about 15% of people in Colorado who are reporting that they have what they're considering, so this is self-report or else parent report, so they're considering poor mental health. So if we compare this to 2017, which is the last time this CHAS, or the Colorado Health Access Survey data, was completed, that's gone up. So in 2017, it was 11.8%, and that was the last year that the survey was completed. And for 2019, 13%, 15%, sorry. We do know that too, that over 13% of Coloradans don't get the mental health care that they need when they need it. More than 1 million Colorado adults are saying that they or a loved one or a close friend has been either addicted to either drugs or alcohol. But if we think about that number, we've got actually a little more than 95,000 adults in Colorado saying that those people went without needed treatment. So this next slide might not seem relevant to the topic, but I want to pull it in because as we're looking at statistics, I think it's important to look at some data that we might not immediately think of when we think of supporting behavioral health and what we can do in communities and what we need to be paying attention to in communities that can intersect with behavioral health, so mental health as well as substance use. So here's a map of current unemployment rates in Colorado, and this just came out. Some of you may know that yesterday was a big day in terms of the budget. The budget forecast came out, so this came from the Colorado Economic and Fiscal Outlook from the governor's office. So if we look at kind of where we have pockets of unemployment, and just to give you a kind of a lay of the map here, the scale at the bottom is percentage of unemployment, and obviously the darker areas have higher percentages of unemployment, the lighter shades have lower percentages of unemployment. So if we look at areas like Park County, Lake, Dolores, and even sort of looking at Clear Creek, we've got much higher, and some of the rural areas too, not quite as much higher rates of unemployment. And this is percentages based on those who have been in the employment, who have been employed. So 40% between March 21st and April 25th of those people who have been employed are now unemployed. So we've got some significant numbers, and we also know that research that's been done shows that unemployment adversely affects mental health, which is why I wanted to pull this in to the slides today. So when people are losing their jobs, not only is their usual source of income gone, but also their personal work relationships, their daily structure, and also in some ways an important sense of self-purpose is gone, or at least needs to be found in different ways. So as we're working with individuals in accessing mental health care and other behavioral health care, I would encourage us all to think about the intersection of their current employment circumstances and mental health. So sometimes connecting people to mental health care isn't just simply about clinical supports. Ensuring that life events are considered and helping people to navigate through these circumstances is also important. So just a reminder that sometimes mental health care isn't always directly related to, and I think this goes overall for behavioral health care overall, isn't always directly related to direct clinical or therapeutic services, that sometimes we need to ensure that some of these other both social determinants and other life factors are considered in addressing behavioral health. Okay, so I want to switch now a little bit to the topic of policy and legislation. So what has been happening, what's ahead, kind of where are we now in terms of what's going on at the Capitol and policies that have been either passed or were on the cusp of being passed or introduced this legislative session, and sort of where do we go with some of those things given the current circumstances. So the beginning of March, actually, so a couple months ago, typically marked the point in every legislative session when almost nothing is predictable. And sometimes even the most straightforward of legislation can quickly go off the rails for completely unforeseen reasons, such as revenue forecasts or budgeting or compromises or negotiations. So obviously for very different reasons this year, March marked a notable, unpredictable time for everyone. So right around, I think it was probably somewhere between March 11th and March 15th, we all shifted, including the Colorado State Legislature, shifted the way that we're doing our work. So while legislators are still working, they aren't at the Capitol, and session has taken a pretty unique turn. So the impact being felt related to the budget, as well as related to potential public policies that could support behavioral health systems, is that things are either on hold, are being kind of reconsidered given budget constraints, which I'll go into in a little bit more detail in a moment, or are just completely off the table. So, so let me now just sort of give you a little bit of an overview of kind of what was predicted in terms of Colorado's budget and kind of where we are now. So I promise I have a couple of things at the end that will cheer you up. I don't mean to be too depressed in my sort of description of what's going on at this point. I think there really are some opportunities, and I will make sure to cover what some of those opportunities are. And I know Mindy's going to go through as well where our resources are still feeling pretty solid. So in December, we were looking at sort of an economic forecast that was fairly predictable. In March, there was a little bump, but the expectations were still looking at a little dip, but not such a dip that we were going to have to kind of flip most of the things that were being considered in terms of funding. Actual conditions have dropped significantly. So what has happened in the past few months really wasn't anticipated by most people, and you can see that the actual economic conditions are vastly different than expectations. So the revenue forecast was released yesterday on May 12th. So the next big day to look forward to, at least as we know right now, is May 26th, and that's the date when the legislature is due to reconvene. Though that may still be a little bit up in the air depending on how Safer at Home goes. So what the prediction has been is that budget cuts will be a little over $3 billion. That's with a B. So this includes cuts or not funding. So it's going to be either cuts or not putting funding into things that haven't yet been funded but have been passed through legislation. So this includes last year's bills as well as some actually 2018 bills where funds were not yet spent. So this doesn't necessarily mean that programs have been removed from the budget. In fact, in most cases it doesn't, but instead they'll have reduced or no funding attached to them for the time being. So just as a little bit of background around the budget, so the major revenue sources in Colorado make up about, and there are three sort of major revenue sources. It makes up about 96% of the total general fund revenue. And these are individual income taxes and corporate income taxes and sales and use taxes. So all three of these sources saw significant downward revisions since March, which is why you saw that big shift in from the expectations to reality in terms of the revenue. So on the next slide, I'll give you some examples of where it's predicted to occur in the areas where some of these budget changes are predicted to occur in the areas of behavioral health. Okay. So keep in mind that these are a few of them. There are a number more. I mean, behavioral health really weaves in and out of a lot of initiatives and bills that I might not have highlighted here. So keep in mind that these are some examples of possible areas of funds reductions related to behavioral health. But I'm sure there are many of you on the webinar now who may know of another program or a piece of legislation or an initiative and may be wondering about the funding too. So I can try and help answer some of those questions if it's not covered here when we get to the end. So a few examples. The first is Medicaid-assisted treatment in jails. So this is an initiative that actually had started in some areas, but there were jails that had not started. So because some of those funds had not already been spent and were not already encumbered or dedicated to a particular jail or community, that money will be reverted back. Another example is the Special Connections program. Some of you may know Special Connections is a program for high-risk pregnant and postpartum women. The JBC staff had recommended, so it's the Joint Budget Committee, so the staff had recommended a $637,000 reduction. So that actually includes a 50-50 split of general funds and federal funds that were appropriated from healthcare policy and financing. And additionally, there is a bill related to special connections, and that was House Bill 19-1193. And I'm going to mention these House bills and Senate bills and mention the numbers in case people have an interest in following them or looking them up, but don't feel like you need to memorize the bill number. I just want to give you sort of a big picture of where some of these impacts might be. So that was a bill that passed last year, and it's also at risk of a $500,000 reduced appropriation and elimination of a child care pilot program for women who were involved in special connections. So that would be a loss. Next, there's about $3.1 million for rural areas that will be taken back from the CIRCLE program and other rural treatment programs for people with co-occurring disorders program. So that could impact some rural areas and substance use services and supports. The next one is behavioral health professionals in schools. So this was a bill that passed last year, Senate Bill 1910. And that was a program that put an additional $3 million into a grant program for school districts to support behavioral health professionals and social emotional learning and other kinds of ancillary services that support mental health and behavioral health for students. So that $3 million had not yet gone out to school districts, so that is going to be returned. Next, K-5 social emotional health. There was a pilot program that passed last year to do a pilot of licensed social workers in pilot programs to put a social worker assigned to every grade, and that social worker would follow every grade in K through 5th grade. That program hadn't started yet, so the funds for that are not going to be currently available for that program. Just a few more I wanted to highlight. Early Childhood Mental Health Specialist Program. This is an existing program that is housed at the Office of Early Childhood in the Colorado Department of Human Services. There was a bill that would enhance this program by providing some evaluation and some standardization and model to this program, and this was House Bill 20-1006, so this is one that's being considered this year. So this bill actually could move forward, but it has a large fiscal note, which would have to be reduced or eliminated. So anything with a fiscal note is probably going to be in jeopardy. And the last one I wanted to mention is the home visiting for school readiness. And this is the Healthy Steps in Home Instruction for Parents of Preschool Youngsters, or some of you may know it as the HIPPY program. So they had been approved for general fund allocations earlier in the legislative session. However, the recommendation now is that the committee not fund the expansion of these programs, reducing this appropriation for the Department of Human Services by more than $500,000 in general funds, as well as a position that was attached to that. So as we know, home visiting can be an opportune time to identify social emotional needs in young children and behavioral health needs of parents. So I included that as an example in some of these others that aren't necessarily direct clinical or therapeutic services, because as I'd mentioned earlier, when I was talking about unemployment, we need to really understand and address the impact of what may feel like ancillary cuts, not directly related to mental health or substance use, but that those can actually sort of create circumstances for poor behavioral health. Okay, so what is still in place and what can we still count on? What do we have to look forward to? So I want to emphasize that there are still supports and initiatives in place that will support behavioral health needs of Coloradans. So as some examples, I wanted to point out the 5 that I have here, but there's still other initiatives, and I know Mindy's going to go through what resources are available as well, that people can count on. So House Bill 19-1287, that first one I have here, that was last year's bill on navigation for residential facilities tracking system. That will stay because it's already being implemented. So funds have already been allocated to that, and it's already in place. So that directs the Department of Human Services to implement a behavioral health treatment capacity tracking system and a care navigation program to assist people who are obtaining access to treatment for substance use, including medical detox and residential and inpatient treatment. So I also want to mention the Ombudsman Office. So legislation passed in 2018 that established the Office of the Ombudsman for Behavioral Health Access to Care as an independent office. So while funding to this office is actually somewhat limited and not sufficient to fully fund the office is established and it is staffed. So the funds that had been allocated to that are there. However, as I mentioned, the funding to that office is limited enough that it's not fully able to meet capacity of the calls that are coming in. So another one I wanted to pay a little bit more attention to is mental health parity. So mental health parity and the bill attached to that in Colorado, well, the most recent one is House Bill 19-1269, which is the Behavioral Health Care Coverage Modernization Act. So what this did is it really strengthened state requirements in Colorado for insurance coverage of mental health and substance use care. So as many of you know, we've had laws on the books around parity both at the federal and at the state level, but there have really been struggles with implementation. So what the mental health parity bill did that passed last year was essentially say, we know that we have parity laws in place that say mental health needs to be addressed in the same way that physical health coverage is addressed. So it needs to be covered by insurance, as well as when there are any limitations on physical health and mental health, they can't be just for mental health. They have to be, those limitations need to be present in the physical health care arena as well. The next one I wanted to quickly mention is Safe to Tell. And again, you may think of this perhaps as ancillary. So this is a bill, the Safe to Tell program in Colorado, many of you may know, it was set up for students to feel safe with anonymous reporting for what they're considering dangerous circumstances. So if there's a threat, if there's somebody's bringing a gun to school, situations like that. Now there had been some sort of conflation of issues around that, where students who were calling in for mental health issues or suicide risk, who needed more therapeutic intervention, didn't feel that they were getting that. So the Safe to Tell bill clarifies and creates a process for what happens when mental health issues are identified. This had a fiscal note, but it was changed to gifts, grants, and donations. So it's looking at this point like the Safe to Tell bill will continue to move forward. Last one is teacher recertification. This is a bill that that tries to ensure that teachers are getting the, when we've heard, so I didn't mention this, but so right now I'm an independent consultant. I worked for 3 years leading children's mental health, school age and early childhood strategy and initiatives at Mental Health Colorado, which is an advocacy and policy organization, and had started working on this bill and leading efforts on this bill when I was at Mental Health Colorado, and now continue to be concerned and connected to this work. But we heard from teachers that they are really feeling like they need more, not just training, but information and kind of resource, sort of confirming what resources are available to them in their districts, particularly in rural districts, around behavioral health. So what this bill would do is it would require that 10, well, in its last state, we'll see if there are changes to it as it moves forward. But it required 10 of the total number of hours of ongoing professional development over 5 years to be specifically focused on behavioral health content. So hopefully that didn't have a fiscal note attached to it. That was just shifting the requirements for some of the content. And so the hope is that that bill will continue to move forward once the after May 26th, once we hope the legislature reconvenes. So those are, again, some, a snippet of some of the things that we may want to look out for in terms of what may be impacted, but also what we can still look forward to utilizing that's still in place. So what's next? So legislators plan to return to the Capitol to resume the 2020 legislative session on May 26th. Due to the pandemic, our state budget, as you've heard, is unfortunately facing a lot of cuts across state departments. As you may know, we are constitutionally required to pass a balanced budget in Colorado. So therefore, given the current economic recession we're facing and the lost revenue it means for the state, there likely need to be budget cuts, which probably are going to be between about 10 to 20% of our state spending. Moreover, due to TABOR, the Taxpayer Bill of Rights that was passed over 20 years ago, it's nearly impossible for Colorado to set aside money when economic times are strong to save for when the economy is in crisis like we are now, making us actually the only state that doesn't have sort of a rainy day fund. So the budget situation is concerning enough at this point that ideology might not be able to win over budget recommendations. So on a normal day, I would encourage us all to be advocates for our behavioral health system. But where we are today, even the best and most supportive programs probably are going to face cuts. However, this shouldn't discourage us from doing the work that helps Coloradans the most around behavioral health. So we will get through this. I've been looking at sort of economic forecasts and looking at sort of what resources we have in place and sort of where priorities are, and we will get through this. And there will be opportunities to build behavioral health supports back up again. There are many people working on budget options and looking for strategies to minimize impacts of this crisis. Amongst sort of some of this bad news, I do want to provide some, what I think should be reassurance that we can continue to build up what we may be losing in terms of budget cuts during this time. And there's a lot of this work that can continue to happen as we move through this critical period. I think also what's important is to look at lessons learned. So as we're thinking about how behavioral health services and supports have needed to change during this pandemic and during these sort of difficult economic times for many of us, both at the individual level as well as at the state and federal level, what can we learn from this? Are there things that, how have our roles changed, if they have? What have we seen emerge from this related to needs, related to sort of consumer or patient needs related to the work that we do? How might we need to sort of think about shifting that in the future so that we're feeling more prepared? And are there any lessons learned that can help inform the behavioral health system to create a more resilient system down the road? So I'm going to pause there. I do have my contact information here. I know even an hour and a half of time isn't a long amount of time, as we'll probably see once we finish up at 2:30, but excuse me. So I just wanted to pause there and see if there are any questions.
Great. Sarah, thank you so much. One of the questions I think coming is, I think as the JBC gets ready to really look at where they're moving, and then with the current vote, it's my current understanding right now that it doesn't look that if there needs to be 2/3 majority, that we're looking at a state of fiscal emergency. Is that your understanding right now, or do you have any level of, and I guess where I'm getting at, is it some of the dollars that are, I think, at the state level that are constitutionally mandated as well, that it would take a fiscal state of emergency for override. So is it your feeling that there will also be some protections with some of the existing programs if a state of fiscal emergency stays at bay? What's your general sense? Or is it too soon to know?
You know, I'm really not sure. I'll fully admit I'm really not sure. I think there's been sort of so many unknowns at this point. I'm waiting honestly until, I mean, after I saw the revenue forecast yesterday and did not see anything included in there that would indicate that, unless I missed it. There were a lot of documents. If folks want some light reading, I would encourage you to go find the revenue forecast that came out yesterday, and there was a good PowerPoint presentation that both the governor's staff and the JBC staff had put together. Staff had put together, but I'm waiting until the 26th at this point to see what happens there.
Okay, and I think that's prudent. I mean, there's still, like you said, so many unknowns at this point. And I guess what I would say is there's a lot of folks, because our orientation is so much around public health, community engagement, community and behavioral interventions and navigation, and those who are working the communities. And of course, not always necessarily deemed advocates, but so many folks who advocate on behalf of their communities. And I think you mentioned even early on things like job loss, change in security, of what we would consider sort of standard supports, even those moving away can be difficult for people in terms of like really kind of changing up their environment, their really how they're interfacing with the world, confidence, the like. I guess for folks who are out in the field working with the population and who are going through a couple of, going through kind of the COVID-19 piece, some of the change in what we know from a kind of like overall from the economy and the like, I guess what is some advice that you would give folks who are navigators, community health workers, who are working in the field around anything that they can do from a policy area, how to share their concerns, their voice, I guess, as they're interfacing with their people that they represent? I mean, is there any specific advice from sort of making that connection to policy and, really looking at sort of opportunities? Any advice that you would give folks right now? I know it's a hard question.
I mean, it is particularly now because forms of advocacy and are sort of making our voices heard look a little bit different now. We can't just walk into the Capitol and sign up to testify on a bill right now. One, because they're not there. But even when the Capitol opens up on the 26th, we hope, things are going to look different. My guess is there are going to be distancing and protective things that are put in place at the Capitol, so it won't be quite as accessible a process. That's my guess. But given that, so let me talk about legislation specifically. I mean, when legislation goes through the Capitol and goes through the state legislature, it really is an accessible process. There's a website that you can follow that if there's a particular bill that I mentioned today or that you know about that you're interested in, it's pretty simple to go onto the Colorado Legislative website and find that and find the current status of it. So to look at when the committee hearing might be, and to get involved in committee hearings. So that committee hearings are really the place where public input is often most needed, because that's where you can sign up to do public testimony. That's where decisions are made and whether it comes out of committee and goes back to sort of the full body. So I think, and I'm guessing that Mindy can probably answer some of those as well in terms of some of the specific issues that people might be able to get involved in. But I would say when find between now and the 26th, when the legislature reconvenes, find sort of where your concerns are, where your sort of passions are, where your sort of the work that you do, and where that might intersect with some public policies that are in place. Find those and follow them and make your voice heard around them through either public testimony, through written testimony, which we might be getting a lot more written testimony over the next maybe even couple of sessions, given how things have been going with COVID.
Great, thank you. And I think that's really great advice. And I think to your point, it is actually a more accessible and open than people often realize. So finding those dates, times, and I would say, I think to your point that some of the most compelling testimonies for legislation are people who are working in the field and see this every day and really can share. It's great. So thank you so much. That was awesome. So I think, Mindy, if we're ready to go, we'll go ahead and have you start sharing your slide presentation. And I said, while Mindy, you're bringing that up, there is one additional question. Sarah, you had mentioned a web page where people can find legislation and the like that is being supported or what's currently in play. Do you want to share that maybe in the chat with folks? Sarah, I think you might be.
Sorry, yep, I will.
We'll do that. Okay, great. All right, awesome. So we will go ahead and share that, and I'm going to go ahead and pass to Mindy. So Mindy?
Great. Can you see my screen? And my sound is okay? Great. Well, thank you everyone for taking time today to join us. I really appreciate the work that you all are doing. I think it's so important that we have people in the community that are helping people in need to connect to resources that will help to meet those needs. And I think it's so important that you're taking time to learn a little bit more about kind of what the behavioral health system looks like, what some of the issues and challenges are, and some ways that we can work together to collaboratively address challenges. So I'm Mindy Clouden, and I have worked in the behavioral health field for about, well, depending on how you count it, somewhere around 20 years. And most recently, I've been working with Colorado Behavioral Health Care Council, which is the statewide association of community mental health centers. We represent 17 community mental health centers, as well as the 4 managed service organizations, which are contracted by the Office of Behavioral Health to manage non-Medicaid state and federal funding to address substance use disorder treatment. And then we also represent 2 specialty clinics. I'm going to primarily be talking with you about the community mental health center system today, but if there are any questions about the managed service organization, feel free to send those as well. So, what I'm hoping to accomplish today is to give you a good grounding in overview of kind of what Colorado's community mental health center system is, what services we provide, how to access those services, and what are some of the unique characteristics of community mental health centers, as well as the challenges and concerns that we see. I am going to talk a bit about COVID-19 specifically, what that has led us to, the ways that we've pivoted to provide services under this new environment, some of the things that we'd like to see moving forward, and some of the unique challenges that we see coming out of that. And then I'm also going to talk about our policy priorities. And I'm not going to talk as much as Sarah did about specific legislative bills. I'm rather going to be looking kind of broadly speaking at what do we want to see happen, what is our vision for the future, what are our policy priorities, and those form the lens by which we evaluate legislation, and also the lens by which we use to think about what our legislative agenda would be each year. So I hope that makes sense to you all. So a little bit of kind of background on when we're talking about community mental health. So back in 1963, President Kennedy signed the first bill that created this concept of having a community mental health center. And the idea was really that we wanted to get away as a nation from providing only hospital-based or institutionalized care for people that had serious mental illness, and really start to think about ways that we could integrate services in the community and help people to lead more meaningful and productive lives from the communities in which they came from. The legislation that was passed at that time created this concept and kind of outlined what some of the core services would be for community mental health. But what it did not do, and this is important, what it did not do is fully fund behavioral health services. And it did not create a community mental health center program that was comparable to, for example, some of you may be familiar with the Federally Qualified Health Center program. So federally qualified health centers are not only codified in federal law, but they also receive designated funding in terms of grants to support indigent care, and they receive specific payment methodology in both Medicaid and Medicare that is really designed to help ensure that they get full cost-based reimbursement. Now, one could argue that even their reimbursement is not adequate, but it's just important to note that unlike federally qualified health centers, community mental health centers were kind of created as a concept, but they weren't necessarily really fully funded, fully supported. And to this day, that's something that we still struggle with. Now, state level, in Colorado, we started to have the existence of community mental health centers around that same time. There was a statute passed in 1967 that created a designation for community mental health centers within the state of Colorado. And the concept is really we wanted to have community mental health centers that would provide a full range or full continuum of behavioral health services and be responsive to local needs. This is really what has become the basis for Colorado's safety net. And it's important to note, I think, that we have these 17 community mental health centers that do cover every single county in the state. That does not mean that every single county in the state has access to the same level of services, just like with, for example, in other specialties, like oncology is a good example. You might not have an oncologist in every single community or a cancer care center at every single community, because you need to be able to have enough volume of services to provide that kind of necessary care. With that said, all community mental health centers have to demonstrate that they have a full array of services available and look at options to help people access care that might not be available immediately within their surroundings. The community mental health centers in Colorado have seen a significant increase over time in terms of clients that we serve. It grew by 170% in just 12 years and 56.9% in just 6 of those years, the latter 6. There was a slight drop in 2019, and that was just as a result of a decrease in Medicaid eligibles. So this prompts me to want to share a little bit about kind of the populations that community mental health centers serve. We do serve all ages, everything from 0 women that are pregnant and the children that they are carrying, all the way to, I think, our oldest clients. I recall one of the mental health centers saying that they had a client that was 90 years old. And we do serve all kinds of diagnoses and people with different kinds of insurance. With that said, Medicaid is the largest source of insurance for people with serious mental illness, for children with serious emotional disturbances, and for people suffering from substance use, misuse or abuse. 50% of Medicaid recipients have some kind of behavioral health diagnosis, and more than a quarter of spending in the country on behavioral health is within Medicaid. So that's really a big focus for our centers, is contracting with Medicaid and with the regional accountable entities that are managing the behavioral health benefits right now, and making sure that we are able to continually meet the needs of key populations. We also serve people with private insurance and with Medicare and those that are uninsured, and there are significant differences in terms of what those folks are, what our providers are paid to be able to do, and that poses a challenge because we want to provide comprehensive services to all patients, regardless of their payer source. And there are some real gaps, and I think that Sarah parity, because we really are seeing that it is more challenging to serve people with private insurance than Medicaid in many ways, that their benefits are limited, their copays are higher, their provider networks are smaller. Obviously, it's challenging to provide care for people that are uninsured, and we need to rely on philanthropy and state funds and other resources to help us to do that. And then it comes to people with their Medicare resources, really focus on providing what's considered medically necessary for people in terms of behavioral health services, and they do not have, for example, case management or recovery supports, like the services that Sarah was alluding to, helping people to gain employment and really look at how do they continue to feel like they're able to contribute to the community, those kinds of things. So those are also challenges. With that said, the community mental health centers all provide a very comprehensive array of services, and this is really what I think makes them unique from other kinds of behavioral health providers. So this range of services goes from crisis or emergency services. In some cases, they're doing that under contract through the crisis system that you heard about, that Camille was discussing last week. Prevention, screening, and early intervention, outpatient treatment and medication management, and that really, there's a lot that could go into that. So there's psychiatry, medication management, groups that cover a number of different issues, individual and group and family treatment. And then a lot of our providers and mental health centers also have hospital alternative programs and other kinds of residential services. So, we'll talk a little bit about what that has meant within the COVID. Recovery supports is a key component to community mental health centers, and this includes peer specialists, it includes recovery-oriented support groups, things that are, again, really focused on helping people to address their social determinants of health, so not just their clinical needs. Care coordination, navigation, and wraparound services. And I'm excited to know that in a few weeks, you'll be hearing from a couple of our centers about their navigation programs specifically. All of these services are really accomplished in large part due to not just what our centers can do alone, but what our centers can do through their strong community partnerships. So the community mental health centers will often partner with local school districts to provide the kinds of counseling services that school counselors are not able to accomplish. We will partner with criminal justice agencies to do jail-based services, work with CIT officers to offer alternatives to arrest if someone is suspected of, illegal behavior that is actually the result of them having a behavioral health disorder. Those are just a few examples, but we have many community partnerships in place. The piece of what our members offer and what CBHC offers statewide is Mental Health First Aid Colorado. I think that this is something that's worth folks working in the navigation and community health worker space knowing about, as if you have not been trained in mental health first aid, you may want to obtain that training, but also you may identify needs for other community agencies that you're working with to obtain this. The idea behind mental health first aid is really just like you think of first aid, that you can be an emergency responder as a layperson, and that you're trained to identify warning signs of mental health and substance use problems, and you can respond to those problems. A few benefits of the mental health first aid courses. It increases mental health literacy and awareness, expands individuals' knowledge of how to help someone in crisis, connects individuals to services and resources in their community, reduces stigma and increases compassion, and provides us with a common language to discuss mental health issues. And I should say it's really behavioral health issues, not just mental health. Mental health first aid is currently in the process of developing an online training course, largely in response to the pandemic, so that will be available. So I'm going to move into talking a little bit about some of the factors that we see limiting access to behavioral health care. So stigma is certainly still around, it still exists. And really, I think some of the factors that contribute to stigma is that people in society continue to see mental health conditions and substance use disorders as a moral issue, rather than what it truly is, which is a chronic disease. And I think that there has been some shift. I think that there's been a lot of work done in Colorado and elsewhere in the country to help educate and inform people and to mitigate stigma, but it is an ongoing challenge. And this is exacerbated when people are concerned about things like they seek help and they're seen as having a behavioral health disorder. They might lose one's job, experience child welfare issues, or potentially be at risk of civil commitment. Navigating complex systems, just like all of healthcare, behavioral health is fragmented by payer, and it is administratively complex. And so again, the work that you all do as care navigators and community health workers is so important, and we do need to continue to look at ways to simplify and increase access to care. Insurance coverage. As I mentioned, one of the big challenges that we have is seeing people that have private insurance. And the reason that this is challenging is because sometimes that private insurance has a limited provider network. There are hoops to go through in terms of prior authorization or medical necessity requirements. And some providers, some behavioral health providers are not even wanting to contract with private insurance because their rates are so low. And so it makes it hard to actually have the capacity to provide the services that are necessary. We do need stronger enforcement of parity. And while that's something that Colorado is working on, it's going to be, something that continues to need our attention. Provider reimbursement is so critical because if you don't have an adequate workforce, you can't have adequate access to care. And so, what we're looking at is there are challenges in terms of having enough licensed and credentialed providers that can provide the care that you can actually bill for. So there's kind of credentialing issues. There's rates that are not fully meeting the cost of care. And that's a historical issue that has never been right-sized. And then there's really been limited opportunities for behavioral health providers to participate in alternative payment models or to look at ways of being paid that are not directly and solely tied to encounters. So in other words, how do you provide a way of paying providers that is really more around the value that they bring to the community rather than the number of, billable, encounterable services. So on top of all of that, we now have, as we've all been experiencing, a significant impact from the pandemic. And, you know, I've heard people talk about this in terms of, we had kind of the first wave of hospitalizations and acute care needs on the physical health side, and there may be a second wave of that, but really we are preparing for the inevitable second wave of behavioral health demands. Because as we've all experienced, every one of us on this webinar, I'm sure, the pandemic has created all kinds of feelings of anxiety and depression, loneliness. I personally have been having trouble sleeping. I know that there is increased propensity to be using substances in unhealthy ways. And you know, we really know that we're going to need to shore up the behavioral health safety net, not only to continue to care for folks who already had diagnosed behavioral health needs and conditions, but also now folks that, you know, as a result of unemployment or as a result of the stressors that have come about from this pandemic, now present with brand new needs. There were so many different slides I could have brought in around this. There's one that I actually just saw that I could have brought in around kind of what we anticipate seeing nationally around what's called deaths of despair. But what I did want to share here is just the extent to which people that are being surveyed. So this is not conjecture. This is actual. You know, what are people saying about the impact that coronavirus and the COVID-19 pandemic has had on their mental health. And what you see here is that across male and female, across people of different racial and ethnic backgrounds, people of different ages, nearly 50% of people are saying that it has had either a major impact or at the very least a minor impact on their mental health. That's nationally. And then within Colorado, the Colorado Health Foundation worked with Magellan Strategies to conduct the survey, and they found that at least 53% said that yes, COVID-19 is having a negative impact on their mental health. So all of that is to say that we know that there is a need for us to make sure that we have providers and resources within the community to address these issues. So I'm going to chat a little bit with you about how our members have been responding to the pandemic. I've been so just so honored to be connected to the members of CBHC, because we really have stepped up to the plate, and CBHC members have continued to provide face-to-face services, you know, adhering to strict safety guidelines, scrambling desperately to get enough protective equipment, and you know, offer safety guidelines to our clients and staff. But where we've continued to do things face to face has been where we've had no choice, right? Where we have to, because people are in inpatient facilities, in residential facilities, in such as detox would be an example. In addition, we've really pivoted very quickly within the course of 24 hours, I would say, to being able to provide services using telehealth. And doing that has meant that we've had to increase our outreach within the community so that folks knew that our doors were open, just in a new way. And thankfully, we've had a really nice partnership with the state, both with the Department of Healthcare Policy and Financing and the Colorado Department of Human Services for their Office of Behavioral Health, in terms of obtaining some emergency flexibilities that have allowed the provision of telehealth services for behavioral health using the telephone instead of requiring a video screen, which certainly helps folks in rural areas that may not have good broadband access. It certainly helps folks that are nervous about using the video or competing. You know, there's households where you've got multiple parents and multiple children all on the internet all at once. And so being able to do that service by telephone has been really important. We've also been able to obtain a verbal consent to treat, so people didn't have to go into the clinic to sign anything. And we've been able to expand our wellness and clinical services into the evenings and weekends, which has, you know, really helped for working parents and for children that are attending school via teleschool. So I do want to encourage you to visit that website, because on that website we have information about all of the community mental health centers. We have some wellness resources around kind of taking care of yourself during the pandemic, and other information that might be useful to you. Community mental health centers have also, since their founding in Colorado, been actively engaged in disaster response, and that has typically been at the local community level. So things like responding to the Aurora theater shooting, or responding to fires or floods, and providing you know, emergency services to the community in terms of dealing with those trauma. Each center has a disaster response coordinator. And now with COVID, we're really also stepping up to look at how do we do this work statewide, and provide crisis counseling to first responders, healthcare workers and other essential workers, community-based support groups that are often free to the community, on just things like coping skills, and then other partnerships with state and local public health agencies. We're also working with the Colorado Department of Public Health and Environment on setting up, using federal emergency management funds, setting up emergency crisis counseling. So this is just, you know, again, showing you our website that we stood up. We had a website, but we enhanced the website in response to the pandemic. And I'd encourage you to come visit that and to share that information with the organizations and clients that you're working with. So as Sarah so eloquently talked about, you know, we're really in a situation where we're looking at this increased demand for behavioral health services, and some new costs that come with, you know, pivoting to provide care in a new way. Yet we're facing severe revenue decreases because billable encounters have been down, but also a decrease in rates and in reimbursement rates. And so, you know, this creates this tension where we want to continue to have capacity. We want to continue to meet emerging needs. We want to continue to be there for our communities. But we really need to find new ways to be able to support providers in order that providers can support communities. So I don't need to get into too much detail because you know, Sarah spoke a lot about this. I think that the reality is that the budget is in a more grim situation than it has been ever. This is not a recession. This will be a depression. Thankfully, one of the things that has been happening is that the Joint Budget Committee, lawmakers, the administration have been really thinking as much as they possibly can about how do we avoid cutting core services and maybe look at where there are opportunities to perhaps something was authorized last year but not implemented yet. You know, are there things like that that we could cut? But the reality is this will be across the board. So, you know, we have to know that that's coming. So CDHC's policy priorities, and these are not, these are what they were before COVID, but there are, you know, there's like some nuances to them now. So CBHC supports alternative payment models that offer increased flexibility and enable providers to respond to emerging community and client needs. And what I'm really talking about there is that we want to continue to explore ways of supporting behavioral health services that are not solely tied to an encounterable or billable service, but also look at how do you support providers to be there for the long term for their communities, and how do you really look at value rather than just volume of care. The second principle or priority is that we support policies that promote a full array of mental health and substance use disorder treatment services that meet the needs of Colorado's diverse population and communities. So we don't want to see, just as an example, we don't want to see an investment in behavioral health services in primary care, which are very much needed, but we don't want to see that come at the expense of specialty care. Or we don't want to see an investment in prevention, which again is very much needed, come at the expense of residential treatment, because the whole array is needed. And the reality is that people that have behavioral health conditions may have one level of need that changes. They may have a serious mental illness that requires them to be temporarily hospitalized. And as they recover and become stabilized, their needs change dramatically. And so you need a system that looks at providing the full array and helping people where they are in that continuum. We support policies and program models that will help build Colorado's behavioral health workforce. So we really want to see where there are opportunities to increase not just reimbursement, but reduce administrative burden, where there are opportunities to look at how the credentialing process works and other strategies to help support people going into this line of work and staying in this line of work. And then, as I just alluded to, we're also very interested in supporting policies that promote accountability, but while reducing administrative burden and increasing alignment. Just a few more things about the behavioral health workforce crisis. We do have an aging workforce. This is particularly true for psychiatrists. And there is a dire shortage of psychiatrists across the country, including child psychiatrists. There's a shortage of new professionals, new folks going into this work. And geography is a key factor in this. It's very challenging for some of our rural community mental health centers to recruit providers as folks have gravitated towards the cities and towards the Front Range. There's a salary disparity between systems. And what I mean by that is that it's very difficult for community mental health centers to compete with larger hospital systems and to compete with other kinds of providers that may be employing behavioral health. And so we need to be able to continue to look at how we address the parity between behavioral health providers and primary care providers and other specialists, and how do we continue to address the disparity that exists between community behavioral health and, for example, hospital care. And then credentialing and billing issues, making sure that we're really enforcing that we need an adequate provider network, and that the way that we look at what constitutes an adequate provider network takes geography and rural needs, transportation needs, all of that under consideration. So comment about administrative burden. While this is a funny little image, this could very well be the amount of paperwork that our providers need to accomplish in order to conduct an intake with a client, satisfy requirements from multiple different payers, satisfy requirements from multiple different regulatory agencies. And so, we need to look at ways to align what's required of providers across the different agencies that have some role in regulating behavioral health. And then at the state level, we need to look at, are there opportunities to create efficiencies at the state level so that more of the investment can go directly to client care. I talked about payment models, but I really want to be clear that what we're looking to do is to make sure that we have reimbursement rates that put behavioral health on par with other specialty kinds of providers and with primary care. And we want to look at payment methodologies that support volume over capacity and value or quality over quantity. So there are a couple of national models that, while we're not, CBHC is not actively enforcing any of these models at this time, they are some things that we're taking a look at. One of those is the Certified Community Behavioral Health Clinics model, or CCBHC. I mentioned earlier that unlike, for example, federally qualified health centers, community mental health centers really haven't had a federal definition tied to them. They haven't had a single set of defined services or a single set of reporting requirements or ways of assessing the quality of community mental health centers across the country. The Certified Community Behavioral Health Clinics program was instituted as one way of trying to do that. And so it's currently a demonstration project. It's not a permanent part, not codified in federal law permanently, but our counterparts at National Council for Behavioral Health are actively working with Congress to try to accomplish that. And along with the CCBHC model comes a prospective payment system tied to actual costs for those providers that meet the definition of a CCBHC. Another model that's been used across the country in about 30 different states, but not in Colorado, is the creation of Medicaid health homes for persons with chronic conditions. And this provides, while not touching the core way that providers are reimbursed, it adds on top of that a per member per month payment that supports care coordination and care management services for people with serious mental illness and or 2 or more chronic conditions. So those are just a couple of the things that we've been taking a look at. I also wanted to mention that while we're anticipating that there will be kind of this surge in increased behavioral health demand, we're also anticipating that there's going to be a surge in Medicaid enrollment. The Medicaid Office at Healthcare Policy Financing has some projections around that. And what that means is that we're going to see increased demand within the Medicaid among Medicaid members. And so our members, the CBHC members, are really gearing up to help meet that need. But while that said, there's a little bit of kind of uncertainty around the level of acuity of what those folks will need, but we are anticipating that it will be a higher level of acuity than perhaps some folks may be thinking about. So I hope that I've left ample time for discussion and Q&A, and this is my contact information. I would love to engage with you all now and just kind of hear how I can be helpful and what questions my presentation has raised for you.
That you had mentioned, I think the mental health first aid opportunity, where Navigators CHW, Erin, we've done some work in terms of providing that resource for folks. And I really love your point around, that healthcare extender, where you see CHW's Navigators also really involved, and we're going to hear from folks who are integrating. What advice, Mindy, I guess, would you give folks who are really interested in learning more about how to connect with what they're doing and want to find an appropriate level of how they can help in their community as navigators or community health workers, how they really maybe beef up skills or really think about their role and scope with the rest of the team? So you talked about mental health first aid as one opportunity, but I guess I was wondering a little bit further about like what are those connectivity or resource points for folks?
So I'm not sure I fully understand the question, but let me try to answer it and then tell me if I missed it. So
yes.
So I think that one of the ways that I would think that navigators and community health workers could be really helpful is to help clients to think about what are all of the different resources in a community, what are the ways that they can address social determinants of health, and providing, whether they be one sheets, whether they be actually helping people make the direct connections, but helping to support, because oftentimes the providers don't have as much time to spend doing that. And so the community mental health centers, as you'll hear later in this series, but the community mental health centers that actually have navigators on staff, have community health workers on staff, that's part of the way that they help support their clients, is connecting them with other services, helping to mitigate any barriers they may have to accessing those services. Oftentimes those might be, how do I prepare for a primary care appointment? In this world, it might be, now that I'm going to have a telehealth appointment with my provider, how do I maximize that time with them? Things like that.
Okay, I think that's really good advice. And I know that resource connection is a huge part of what is out there. And I think you both spoke of great resources that might be good for PNTC and all of us to put together on some level from the state-based, and then ultimately being aware of local. So I guess, Mindy, going to the points around what I'd asked Sarah, I guess, with your perspective too around like where the budget is right now, and you're talking a little bit about these specific cuts, and then what we should maybe be considering. I mean, is there anything else coming up for you based on what we might be seeing ahead, based other than what you presented?
So one of the things that I was thinking about when you asked Sarah that question, and kind of how folks can engage in advocacy right now, is I suspect that many of you are interacting directly with clients, and so you're hearing the stories, you're hearing what they're going through, and you'd be able to provide strong testimony to what we're actually seeing in terms of needs and how cuts will impact people's ability to have their needs met. In terms of what I think might happen at the state level, I think a lot is yet to be seen in terms of how federal assistance can be used by the state. There are some pretty strict parameters that have come with the various packages. One of the things we're really hopeful for is that there will be another round authorized by Congress. There was some direct provider assistance that went out to Medicare serving providers. Most of our centers won't really benefit from that, or the benefit will be very minimal, because again, Medicaid is such a bigger piece of who they serve. And so we're really hoping that safety net providers that predominantly serve Medicaid will gain access to some kind of federal relief.
Okay, great, thank you. So there's a question in the chat from for Mindy and Sarah both, and then we'll open up the lines. But there's a question around, qualifying the word health. And so oftentimes we make a distinction between physical and mental health. If we talk about it just as health holistically, could we look at situation where therapists could be considered mid-level providers like NPs and PAs, and psychiatrists are the MDs? So if we had a model like that, would it eliminate the disparities in reimbursement and coverage? That's the question. Yeah. So Mindy, and then we'll have Sarah share some perspective.
I mean, I think it's a great question, and I've done a lot of work in integrated care, and I'm a big proponent of integrated care. I think one of the challenges is that if you don't talk explicitly about behavioral health, and if you don't train people to understand the specific conditions and specific issues, then sometimes that it becomes like the stepchild, it becomes forgotten. It's a little bit like how I have a friend who I had the same conversation with, and she likened it to, she's an African-American woman, and she said, if you want to be colorblind, you're not going to talk about race. And if you don't talk about race, you're not going to address disparities. So it's a little bit of kind of a double-edged sword, I think. I think we want to acknowledge and recognize that behavioral health is part of health, and it impacts people's physical health, and people's physical health impacts their behavioral health. And at the same time, if we fail to recognize that there's that that there are some that there's specific training needed around behavioral health to meet unique challenges of behavioral health conditions, then that might do us a disservice as well.
Okay, great. Well, thank you. And Sarah, anything else to add? And then we will open up the lines for anyone who isn't able to chat, and we'll just have a few minutes. But Sarah, any closing thoughts?
I would just quickly add to that, I think a lot of what we need to think about when we're thinking about physical and mental health and some of the differences and some of the overlap, both in the characteristics, sort of how it manifests within individuals, but also what the system looks like, is the whole promotion and preventative side. And I think often we get very focused on the treatment and intervention side of both behavioral and physical health, but there are so many, and that's where we talk about specialists and very specific training that's needed, which is important. But I think there's a whole area that where everybody can have a role in supporting and promoting behavioral health, just like they can with physical health, in early care and education classrooms, in schools, in primary care practices, at home with home visiting. So I know this doesn't exactly answer the Q&A, the question that came in about, can't this all just be under the category of health? But I guess I would encourage, as we're thinking about sort of the intersections and of health and sort of how health can be the umbrella of both mental and physical health, that there are a lot of kind of triaging things that lay people can be doing. That you don't need specialization, not in terms of treatment or clinical practice for sure, but in terms of supporting social emotional health, creating sort of healthy environments where social emotional and sort of mental wellness can grow, that we all can have a role in, that doesn't need a whole lot of specific training or specialization.
Yeah, that's a great compliment to what I said, Sarah. Thank you so much for adding that.
Great. Thank you. I think that is really helpful. Erin, should we try to open up the line? So everybody bear with us. If you have barking dogs or anything in the background, it might be loud for a minute, but we're going to try to open up the lines to give those who couldn't get a chance to, in the Q&A, ask something verbally. So Erin's going to go ahead and open up, and we'll just wait for a couple of people to chime in. And if we don't hear anything, we'll close it down. But Erin, I'll let you do that.
Right, and while I'm doing that, if anyone wants to talk, respond to that message that I put out, and I can specifically unmute you. So otherwise, I'm just going to do the ones on the phone because I know they may not be in front of their computer.
Okay, great. So the line is open if you have a question. Going once, twice. This would take me the whole time to find the mute button. So, okay, good. And so for anyone who was on last session, if we did miss a Q&A from you, we apologize. We're going to try to make sure that by land, air, and sea that we capture it. It doesn't look like we're having anyone with additional questions. Is that right, Erin?
Nope, none that I've seen.
Okay, great. And we are right at the close of our time. So Sarah and Mindy, a million thanks for being on. This is great. We really appreciate it. And I think that as our Alliance and the PNTC, we will continue to stay connected about the resources and opportunities, and really appreciate your time. So Mindy, any final thoughts for today?
No, just if anyone has any questions they didn't get to ask today, feel free to reach out to me.
Great. Sarah?
Same thing, just, it was great to have this opportunity. Hopefully everybody walks away with some little gem or two, and feel free to get in touch directly if needed.
Awesome. So everybody, same time, same place next week, and we'll start to hear a little more about some of the suicide prevention work and resources, and then we'll really delve into some strategies I think that we're seeing with Navigation Community Health Worker, which I think ties into some of the work we've talked today. So thank you guys all very much. Erin, anything about evaluation, and are we ready to close down?
Yes, if you could please complete the really quick evaluation that will pop up when you exit the webinar, we really appreciate it, and will help us address any future topics that might be on your mind. Also, look for an email with the slides. I will send that out to everyone who attended. Thank you so much.
Awesome. Very good, everybody. Have a great day. I'm going to reward my dog who's remained bark-free for a whole hour and a half.
Yay, mine too.
Have a great
Bye-bye.
day, everybody. Stay safe. Thank you.